Hi, I'm Dr. Danny Bega. I'm an associate professor of neurology at Northwestern University and the director of the Huntington's Disease Clinic at Northwestern Medicine. On behalf of Teva Pharmaceuticals, I welcome you to this case study presentation, in which we will explore the journey of a middle-aged woman with Huntington's disease, or HD. By exploring this patient's story, we aim to enhance understanding of HD chorea, and we will highlight key clinical features, diagnosis, impact of symptoms, and treatment options. Our patient, let's call her Christy, is a woman in her early to mid-40s. Christy previously worked in an office, but is currently a stay-at-home mother with 2 young adult children. She has a family history of HD, with her mother and grandmother both affected by this condition. Her mother passed away in her 40s. Given her family history, Christy requested pre-symptomatic testing for HD, which revealed 43 CAG repeats in the HTT gene on chromosome 4. Additionally, she experiences anxiety and is on a selective serotonin reuptake inhibitor, or SSRI, to help manage it. She is also chronically underweight. HD is a hereditary neurodegenerative disorder caused by an expansion of CAG repeats, 36 or more, in the Huntington gene. This genetic mutation leads to the production of a mutant Huntington protein, which is central to the disease's pathophysiology. There are approximately 200,000 patients at risk of developing HD in the United States. HD is characterized by a triad of cognitive, behavioral, and motor symptoms. Cognitive impairments often precede the diagnosis of HD by many years. Emotional and behavioral symptoms vary among individuals over the course of the disease. Nearly 90% of patients ultimately develop chorea, which is characterized by continuous, involuntary, random, jerk-like movements that can occur early and continue throughout the course of the disease. Chorea, regardless of the level of severity, can impact patients' daily activities and functioning. Patients with chorea may have trouble with mobility and may require aids such as a cane or a walking stick, may have trouble getting washed and dressed without help, often need help preparing and cooking meals, and can have difficulty taking medication or eating without assistance. Chorea has been reported as the most impactful symptom of HD by care partners. Christy first presented to the HDSA Center of Excellence complaining of movements in her fingers and toes. Her aunt expressed concerns about Christy's ability to drive safely and manage her finances effectively. However, Christy reported being completely independent and capable of managing all her activities without assistance. This lack of self-awareness made discussions about her driving and financial decisions particularly upsetting for Christy. Patients with HD often exhibit anosognosia, or lack of insight, which can result in their inability to recognize or accurately assess their own symptoms. Therefore, it may be helpful to get the care partner's perspective when determining the impact of symptoms. Though Christy did not report any cognitive concerns, her Montreal Cognitive Assessment, or MoCA, revealed mild cognitive impairment with a score of 23 out of 30. Emotionally and behaviorally, her anxiety is well managed with an SSRI. She has no issues with sleep. A motor exam identified mild finger and toe fidgeting, dysarthria, impaired saccadic eye movements, and choreathetosis in distal extremities, with choreiform movements noted while walking. Despite these symptoms, she expressed no interest in treating her chorea at that time. Christy was referred to a multidisciplinary care team for additional support and was advised to schedule follow-up visits every 4 months. As part of Christy's multidisciplinary support, she was given a referral to a physical medicine and rehabilitation specialist who provided tailored exercise recommendations aimed at enhancing gait and balance, thereby reducing the risk of falls. A dietitian created a nutritional management plan focusing on addressing Christy's chronic low weight. A speech therapist performed a swallowing evaluation. Additionally, a social worker worked with Christy to navigate discussions around giving up driving to improve her safety, offered assistance with financial management and organizing medical appointments, helped her understand disability benefits and long-term care planning options, and connected her with support groups. Finally, a genetic counselor provided education and insights about genetic risks to help Christy in discussing testing options for at-risk family members. At a follow-up visit a year later, facial, orolingual, and trunk chorea were observed, limb chorea was more pronounced, and Christy could not complete a tandem walk. Her total motor score, or TMS, was 18. The TMS is one part of the Unified Huntington's Disease Rating Scale, or UHDRS, which offers an overall assessment of various domains of motor function, including chorea, dystonia, tongue protrusion, eye movements, gait, and balance. Christy also reported increased anxiety and was no longer driving, per ongoing counseling from her social worker. She was living with her aunt, who assisted with medication management, doctor appointments, finances, and daily activities. Separately, her aunt expressed concerns about Christy's poor financial decisions, impulsivity, and excessive substance abuse, all of which appeared to reflect the increasing impact of her disease. At this point, both observation and testing confirmed that Christy's chorea symptoms were affecting her balance, ambulation, and social interactions. Understanding the impact of HD chorea on patients and care partners is crucial when making treatment decisions. To assess impact, it's important to engage with both the patient and their care partner by asking questions that require thoughtful responses versus replying with a simple yes or no. Asking about the patient's quality of life, successful completion of daily activities, and physical or psychosocial challenges may help patients or care partners convey the true impact of mild or early stage chorea and help prioritize treatment decisions. One question I often ask is whether they have noticed any changes or impacts on their speech, or if others are finding it difficult to follow what they're saying, because speech articulation can be a sign of chorea in the orobuccolingual area. After carefully considering the impact of chorea symptoms, Christy and her doctor arrived at a shared decision to initiate treatment with AUSTEDO, a VMAT2 inhibitor approved for the treatment for HD chorea. To address Christy's increased anxiety, she was referred to a psychiatrist who subsequently adjusted her treatment plan by increasing the dosage of her SSRI. AUSTEDO XR is a one-pill, once-daily treatment option for adults with chorea associated with HD. Careful consideration should be taken when prescribing due to the increased risk of depression and suicidality in patients. Prior to FDA approval, clinical trials were conducted using the BID AUSTEDO formulation. The first HD study was a randomized, double-blind, placebo-controlled trial designed to assess the efficacy and safety of AUSTEDO. Treatment duration included an 8-week dose titration and a 4-week maintenance period. The primary efficacy endpoint was the treatment effect of AUSTEDO versus placebo, as measured by the total maximal chorea score, or TMC score, from baseline to maintenance. The TMC score is an item of the UHDRS TMS, which scores movements in 7 parts of the body, including the face, mouth, arms, and legs from 0 to 4. A complete TMC score ranges from 0 to 28. The lower the score, the less severe the chorea. At 12 weeks, TMC scores improved 4.4 points with AUSTEDO versus 1.9 points in the placebo group, approximately a 40% reduction in chorea severity. 90% of patients saw improvement in their movements versus baseline, of which 33% achieved a 6-point or greater improvement compared with 2% treated with placebo. The study also looked at the changes in the UHDRS TMS, which showed greater than 2 times reduction in total motor impairment with AUSTEDO versus placebo. Improvements in physical functioning were assessed using the 36-item Short-Form Health Survey, or SF-36, physical functioning score. Patients taking AUSTEDO achieved a greater improvement in SF-36 physical functioning scores at 12 weeks versus placebo, and reported improvement in their ability to perform daily activities like walking, bathing, dressing, lifting, moderate to vigorous activities, climbing stairs, and bending, kneeling, or stooping. The most common adverse events, or AEs, in the AUSTEDO group were somnolence, dry mouth, diarrhea, and fatigue. Once patients were titrated to their maintenance dose, these AEs were no longer reported. 2% of participants taking AUSTEDO withdrew from the study due to side effects. AEs of special interest, Parkinsonism, akathisia, restlessness, and suicidal ideation were not reported during the titration phase. During the maintenance phase, they were reported in 4% or fewer of patients in both arms. Anxiety was reported in 4% or fewer of patients in both arms during the titration and maintenance phases. Now let's look at results from the open-label extension study that evaluated the long-term safety of AUSTEDO. In this study, which was not placebo-controlled, 119 people with HD chorea received AUSTEDO for about 3 years. This study showed that AUSTEDO maintained chorea improvement of HD over the long term. TMC score reduction was maintained for about 3 years, and there were no new safety concerns in this study. The flexible dosing of AUSTEDO XR allows for effective and tolerable control of chorea symptoms. This one pill, once daily formulation starts patients at a 12 milligrams per day dose and then raises the dose by 6 milligrams per day every week until the patient reaches a dose that provides effective chorea movement reduction and is tolerated. The maximum dose of AUSTEDO XR is 48 milligrams per day. The average dose in trials was greater than 36 milligrams daily. AUSTEDO XR should be swallowed whole. Tablets should not be chewed, crushed, or broken. To get your patients started on AUSTEDO XR, a 4-week titration kit is available through sample or prescription. Patients can titrate to 30 milligrams per day using the 4-week titration kit, after which the dose can be further increased as appropriate. Christy was started on the AUSTEDO BID formulation at 6 milligrams twice daily and titrated to 24 milligrams twice daily. With FDA approval of the extended-release tablets, Christy transitioned to AUSTEDO XR at a dose of 48 milligrams per day. As a result of treatment, there was reduction in the amplitude and severity of involuntary movements affecting her limbs, trunk, and face. Enhanced truncal stability during ambulation was also observed. Despite her initial anosognosia, Christy reported improvements in her physical functioning, such as decreased clumsiness while holding objects, eating, and drinking, along with improved gait and balance. Overall, she was satisfied with her treatment with AUSTEDO XR and expressed a desire to continue with it. Her TMS improved from 18 to 11. Her family members noted that they were less distracted by her facial movements and observed that her speech had become more articulate. As her HD progressed, Chrissy began experiencing symptoms of increased irritability and agitation. In response, an atypical antipsychotic was added to her treatment regimen. It is important to note that while atypical antipsychotics can be prescribed to manage psychiatric symptoms associated with HD, they are not approved for the treatment of chorea. Christy is currently on a regimen that includes AUSTEDO XR 48 milligrams per day, an SSRI, and an atypical antipsychotic. To summarize, AUSTEDO has demonstrated efficacy in controlling chorea symptoms as shown in placebo-controlled studies, with improvement maintained for approximately 3 years in an open-label extension study. It has a demonstrated safety profile. Studies have also shown significant improvements in physical functioning, leading to a reduction in disability. AUSTEDO XR is designed with flexibility to provide effective and tolerable symptom control, along with convenient once-daily dosing. Thank you for watching this case study presentation. I hope it has provided you practical knowledge that can be effectively applied in your clinical practice to enhance the care of your patients with HD.
AUSTEDO XR and AUSTEDO are indicated in adults for the treatment of chorea associated with Huntington's disease and for the treatment of tardive dyskinesia. AUSTEDO XR and AUSTEDO can increase the risk of depression and suicidal thoughts and behavior, suicidality, in patients with Huntington's disease. Balance the risks of depression and suicidality with the clinical need for treatment of chorea. Closely monitor patients for the emergence or worsening of depression, suicidality, or unusual changes in behavior. Inform patients, their caregivers, and families of the risk of depression and suicidality, and instruct them to report behaviors of concern promptly to the treating physician. Exercise caution when treating patients with a history of depression or prior suicide attempts or ideation. AUSTEDO XR and AUSTEDO are contraindicated in patients who are suicidal and in patients with untreated or inadequately treated depression. AUSTEDO XR and AUSTEDO are contraindicated in patients with Huntington's disease who are suicidal or have untreated or inadequately treated depression. AUSTEDO XR and AUSTEDO are also contraindicated in patients with hepatic impairment, patients taking reserpine or within 20 days of discontinuing reserpine, patients taking monoamine oxidase inhibitors, MAOIs, or within 14 days of discontinuing MAOI therapy, and patients taking tetrabenazine or valbenazine. Clinical worsening and adverse events in patients with Huntington's disease. AUSTEDO XR and AUSTEDO may cause a worsening in mood, cognition, rigidity, and functional capacity. Prescribers should periodically reevaluate the need for AUSTEDO XR or AUSTEDO in their patients by assessing the effect on chorea and possible adverse effects. AUSTEDO XR and AUSTEDO may prolong the QT interval, but the degree of QT prolongation is not clinically significant when AUSTEDO XR or AUSTEDO is administered within the recommended dosage range. AUSTEDO XR and AUSTEDO should be avoided in patients with congenital long QT syndrome and in patients with a history of cardiac arrhythmias. Neuroleptic malignant syndrome, NMS, a potentially fatal symptom complex reported in association with drugs that reduce dopaminergic transmission, has been observed in patients receiving tetrabenazine. The risk may be increased by concomitant use of dopamine antagonists or antipsychotics. The management of NMS should include immediate discontinuation of AUSTEDO XR and AUSTEDO, intensive symptomatic treatment and medical monitoring, and treatment of any concomitant serious medical problems. AUSTEDO XR and AUSTEDO may increase the risk of akathisia, agitation, and restlessness. The risk of akathisia may be increased by concomitant use of dopamine antagonists or antipsychotics. If a patient develops akathisia, the AUSTEDO XR or AUSTEDO dose should be reduced. Some patients may require discontinuation of therapy. AUSTEDO XR and AUSTEDO may cause Parkinsonism in patients with Huntington's disease or tardive dyskinesia. Parkinsonism has also been observed with other VMAT2 inhibitors. The risk of Parkinsonism may be increased by concomitant use of dopamine antagonists or antipsychotics. If a patient develops Parkinsonism, the AUSTEDO XR or AUSTEDO dose should be reduced. Some patients may require discontinuation of therapy. Sedation is a common dose-limiting adverse reaction of AUSTEDO XR and AUSTEDO. Patients should not perform activities requiring mental alertness, such as operating a motor vehicle or hazardous machinery, until they are on a maintenance dose of AUSTEDO XR or AUSTEDO and know how the drug affects them. Concomitant use of alcohol or other sedating drugs may have additive effects and worsen sedation and somnolence. Tetrabenazine elevates serum prolactin concentrations in humans. If there is a clinical suspicion of symptomatic hyperprolactinemia, appropriate laboratory testing should be done and consideration should be given to discontinuation of AUSTEDO XR and AUSTEDO. Deutetrabenazine or its metabolites bind to melanin-containing tissues and could accumulate in these tissues over time. Prescribers should be aware of the possibility of long-term ophthalmologic effects. The most common adverse reactions for AUSTEDO, greater than 8% and greater than placebo, in a controlled clinical study in patients with Huntington's disease were somnolence, diarrhea, dry mouth, and fatigue. The most common adverse reactions for AUSTEDO, 4% and greater than placebo, in controlled clinical studies in patients with tardive dyskinesia were nasopharyngitis and insomnia. Adverse reactions with AUSTEDO XR extended-release tablets are expected to be similar to AUSTEDO tablets. Please see full prescribing information, including boxed warning, at austedohcp.com.